Let's keep it on the phones here and go and get Dr. Manglona on the line from Public Health. Good morning, Doc.
Good morning. Thank you for having me.
Of course.
Thanks for calling in. Would you like to start with the community testing? You guys are really going to start ramping up things starting Wednesday, and I guess seems like the entire month of June.
Yes, it's going to be a busy month with the test kits. Also, I wanted to point out, too, that some of this has not been posted to the GovGuam web or the DPHSS website. It's partial, but we've added so much that will be updated. But there's a telephone number if anyone has any questions, they can call. But we've got, I think the director may have forwarded a copy of the test site. There were about 10 of them, and it looks like it's going to impact Jigo, Gurat, Dedido, Sananya, Vergata, Inarahan, Mangmang, Totomaiti, Marito, PT, Santa Rita, and Tamuning. So busy schedule.
Yeah. Okay.
Where will we get you off? Which one of those will pick you off? I don't have one for the radio station.
I know. We were wondering. We thought we were going to get a drive-up testing. You can drive up here. Present your nostrils.
I think we're just. Oh no, can't say that. Sorry. Yes, nostrils.
How did last week's testing go?
Okay. Well, good response, and it's nice to have a good response and not have a big burst of cases. So that's a good thing.
Right. Yeah, and I think there was just one, I believe, with a homeless male.
Yeah, and the little cluster that we had talked about before, when that was a very targeted. We had reasons for going in. This is just throwing out a wide net and catch a lot of fish. That when we do targeted, we might pick up a higher number than we throw out a big net. But this is going to be a big net, and it's an island-wide net, and it will let us know what's out there, what's the value of it. If you have symptomatic people, those people are tending to go to their physicians anyway, but if not, we can pick them up. This will also pick up people that have had symptoms or don't have it anymore, or it could be asymptomatic people that are spreading or asymptomatic people that are over it. We don't know yet what we'll get, but that's the reason we're going out there to do the search, to just see where it is and what we're dealing with.
Mm-hmm. And today, we did have people, if you could just provide clarity on the whole situation with the returning Guam residents and the home quarantine. Is there any other information you can provide on that? Like, I know there's a situation with an individual that we spoke with last week, James, right? James, right, his wife flew in from Japan. She had two negative test results, and I'm not sure if they were PCR or if they were the specimen. But she came to Guam to pick up her children. She's a doctor in Japan. I'm not sure if she would be one of those people that would be eligible for this home quarantine, because she's not exactly a returning Guam resident, but she's here on a mission to pick up her kids and bring them back, I guess, to Japan.
Okay. The current executive order it's about to be modified. We all met yesterday, large group of people, and people zoomed in for the meeting at Adelup, and discussed where to from here. How do we modify our current plan? And those things will be changing and will be coming out maybe even today or tomorrow. They're trying to move it out fast, but that will be a little more flexible for returning residents soon, probably this week. You will get revised guidelines where people who have homes here or apartments here will have a little more latitude. Although anyone who's coming back, no matter where you're coming from, if you request to go to the quarantine facility because you really are uncomfortable going home and maybe exposing other people, you will have the opportunity to use the government facility if that's what you choose. Right now, the current executive order is probably going to catch someone like that who's doing a turnaround. Transitors can go through, but if you're going to overnight, you probably are caught by the executive order. It's not a public health order. It's public health enforcing the executive order. So we've had to make certain exceptions for people that were ill and coming back to see ill people, and that's the thing. They've tried to include those people, and with all due diligence they can give without being unfair to others. But yes, it's been difficult, very challenging for the quarantine people. They've been threatened, and they don't have the opportunity to bend the executive order without someone above them saying, okay, make that exception or whatever. And it's fairly rigid right now. So there will be more flexibility in the one that's coming out. And
so is this a guidance or another executive order?
I think it's going to be a modification. I'm not sure what the verbiage will be on it, but it will probably to modify the current one to, I think, the way it's going to be headed, I think, is returning residents. There will be no testing if you're coming from certain areas and you're returning residents. If you're coming from no testing, you just go home and quarantine. Because why is quarantine so important? Because that's the only thing that has stopped it anywhere is quarantine, because there is no vaccine, there is no medicine. So what makes this thing go away? Tincture of time. And what scientific evidence has shown is that 14 days will fairly well cover the majority of the people and the majority of cases. Actually, the majority maybe even covered at 11, but we want to get through the outliers that go out clear to the 14th day, and we've seen that. In quarantine, I think Chima Mbakwa had said yesterday that since we started quarantine, he's picked up 38 cases because of quarantine. Now, they say that one person can infect 2 or 3. His numbers, and this is just a ballpark, he said, we're looking, and he said it off the cuff. He wasn't looking at papers, but he said, I think one person here hits 10 or 15 because of social gatherings and things like that. That's been our experience in bingo and churches and schools and family functions. We tend to gather a lot for those. So if that's true, we may have saved 380 cases on the first go around, and then their 380 contacts, or 380 people with their 10 contacts. It just takes one case to set the stage for another wave. Mm-hmm. So the quarantine's been effective, and so we don't see any reason to waive that, because that's the only thing that's helped us. But at least people can go home and isolate in their home until they feel like they're safe.
Mm-hmm. Was that 38? That number was that the total number of people that have arrived to Guam that were in quarantine that tested positive?
I didn't pin him down on it because I looked back at the traveler number off the dashboard, and so I don't know if he meant. No one pinned him down because he was just talking so fast. Mm-hmm. We picked up, but I know they picked up, and maybe he said 8 because with a mask on and with any accent, it's like, did you say you're committing suicide or I just won the lottery? I can't tell. It's crazy. And he has a. I have a thick redneck accent. He's got a thick, not redneck accent. So it's sort of tricky in hearing his words. But we did. I know for a fact we did pick up cases in quarantine, at least 8 that I can recall.
Right.
This routine, was this meeting yesterday a routine type of meeting, or was this a new meeting?
No, it was not a routine at all. The PAG group, the Physicians Advisory Group, does meet 2 to 3 times a week, and sometimes we will have a special meeting if there's a special concern. And this one was special because we wanted to input from everyone and talk about, because we're heading into a fork in the road, and so we're like, bring everyone. Let's have everyone's input and talk about schools, talk about incoming passengers. I think international, we will still require a PCR test. And why will that be important? That does one thing. For example, let's say you got exposed. You won't probably get symptoms for about day 5. So let's say you go to the airport in any country and you're exposed to a case while you're standing there at the airport. Or even 2 days before you get there. If you had a test right then, it will probably show negative. And then by the time you get wherever you're going, by about day 5, you're going to start being symptomatic. And your shedding has already started before that time, more than likely. So when they get to wherever they're going, they're going to go, don't worry, I test negative. That negative test only means something right that minute.
Right.
And so it doesn't have a lot of value. Positive, any test that's positive has great value. A negative test, it's hold that thought. Okay, that's good for right now, but so what the PCR test will do for any incoming, let's say we have 1,000 people coming in, I guarantee you, if you do PCR testing on that 1,000, you're going to pick up somebody positive, at least one. And that one person won't be getting on the plane with everyone else who clearly has enough viral load to light up a test. At least the other people coming from the international sites will board that plane knowing at least everyone they're sitting next to is negative at that moment. So they'll probably have even if they're infected, it's probably a low viral load. It wasn't enough for the machine to pick it up. So what it will do is weed out the positives before they even board a plane. So that's good. We'll get rid of that. Because a couple weeks ago, like I said, we had a CDC person come in from Hawaii, and 2 people were positive on the plane.
Wow.
Oh.
Yes. So
2 people were positive on the plane when they came in?
Absolutely. Absolutely. Riding with her on the plane. Yes.
Was that reflected in the
Oh, yeah. And we count, every case is counted. Yes. Every case is counted. And I don't know, this is where Chima would help. When did they pick them up? Probably when they went to quarantine and were symptomatic.
Right.
And that's probably 2 of the 8. But the good news is she wore a respirator the entire flight. How in God's name she did that, I don't know, because they're so, you smother after a while. And I think it may have been a 777, and there were only about 20 some passengers on it. So everyone was spaced, crazy spaced, 3 rows apart. So transmission would have been really reduced in that setting. But still, those 2 people wouldn't have made it on the plane at all had we been requiring testing at that point. So that's the value of it. It will get rid of all the positives at that moment that are trying to board.
Were there any other issues that were brought up during this meeting aside from quarantine?
Oh, we hit on everything. We looked at everything, how we're going to move forward. That's the whole topic, is moving forward, and we have plans, and those will all be unfolding, but everything that we can think of moving forward, and to try to keep, it was the whole balloon of all of it, and with business people zoomed in, and physicians, and the governor, and everybody. Sometimes when you have a small group, you'll hear people say, oh, I'll talk to the director about that, and so they make a note. It's nice to have the director, the deputy director, head of quarantine, CDC. It was nice to have everyone, all hands on deck. Right. And because everyone has a different perspective and different thoughts about things that maybe the next person wouldn't have considered. And we had pediatricians there and talked about schools and that sort of thing. So I think you will be seeing official documents coming out that reflect the group, not decision, but the group input.
What was the group called?
It wasn't a group. It was like it started off just as our physicians group, and we're like, hey, let's add so and so, let's add so and so, and so we just kept adding key people, the airport, just different groups. It wasn't really. We don't really have a name for it because it just happened yesterday, and because sometimes in our meetings we'll say, hey, let's have so and so here next week and bring them in and ask them about quarantine and isolation and what the procedures are, and so. This time, because it was a bigger balloon, we're like, hey, why don't we get so-and-so and so-and-so? And I didn't have my glasses on, so I don't even know who all was zoomed in. But I could see little boxes up there with heads on it. So they were there.
I'm the same way.
We wanted to bring up this thing, and I know we had discussed this a little bit over the weekend, but We had got a tip about a 12-year-old, and the info that we had got from the tip was that this 12-year-old boy had passed from COVID, and I'm just going to share with you what I got from Lillian Posadas at the Guam Memorial Hospital. So I messaged her yesterday. Good morning, Lillian. Getting tips about a 12-year-old passing from COVID. Anything on this? I remember we did have a 12-year-old positive. Just hearing from some sources, wondering if you could confirm or not confirm. She responded, good morning, Chris. It's not COVID, and it's not the same 12-year-old. Not COVID. And so then I had asked her to kind of elaborate on, why we'd be getting a tip like that. And she said, Chris, in exercising extreme precautionary measures, we placed the 12-year-old in the COVID Care 3 unit. And although tests and repeated tests all came back negative, we continued to place patient in the COVID Care 3 unit. And so I wanted to get you on because you had said that you could shed a little bit more light on this case.
Let's talk about that. And she's right. I forgot. We did have, when you just said that, I thought, how's this one getting confused? We did have a 12-year-old, I think, or a young boy or a girl. I can't remember.
I think it was a young boy, Doc, who had come in with symptoms at GRMC. He was then transferred to GMH, and then the grandfather had tested positive, but he was asymptomatic. So I automatically assumed it was the same kid.
Aside, because that one probably, because the ages are similar, that may be why that's part of some of the overlap or confusion, because that was a case. This is a different case, and let me tell you, when people come in, right now, if you come in and say, I'm short of breath, I'm this, and you have a fever, you will probably be admitted to GMH until you're ruled out. Some people aren't stable enough once they're ruled out to go to GRMC. We've had a couple cases that it was riskier to move them. And so probably in this case, because the child was sick, they probably just isolated him because that's the COVID facility. And now you got a case there that's not COVID. So they had to treat it in a room that was isolated, just like all the COVID patients. And so they ruled it out just to make sure, but he was kept in that same area. So everyone probably thought that. And again, it's a different case from the first one. And although it proved not to be, but it was, when they're really sick, you're not going to move someone to GRMC just because that's the non-COVID facility. You have to deal with it right where you are, because sometimes moving is very traumatic to patients, and they're temporarily placed on, if they're on a ventilator, which in this case I'm not sure, but if they're on a ventilator, it's tricky to move a ventilator patient to another facility just because. So it was easier just to keep, when they're really sick, keep them safe, isolate them from everyone, and so and that's an isolation facility, so it made it a little easier for them to do that. So that patient was initially and kept in isolation. So I'm sure that's where that came from. Plus, they were ruling it out, and ultimately expired, but due to non-COVID issues. And what kind of issues can a child have? Without going into the specifics of this case, in general, things that affect the lungs, like asthma, if people have an exacerbation of that, that's one thing that can hasten the demise of a child, or cardiac issues. And it's not just, geez, they've got a bad heart. You can get heart infections that even go crazy and affect your heart function and may not result in a good outcome. Infections of any kind that overwhelm the system can do it. And then the kidneys take a hit, the heart takes a hit. So you can have things that on kids that go a little bit south on you, and you wouldn't normally see that in a child, but you might in an elderly person. So there are a lot of other things. You've got blood cancers, lymphomas, leukemias, and there's usually a really clear reason when it's a child because they're so healthy otherwise. And in this case, it was non-COVID. It's going to be in something in that other bucket that didn't go well.
Right, Doc. And so, as we understand that the child passed away from cardiorespiratory arrest, but it was brought on by a multi-system inflammatory syndrome from COVID.
Ruled out. That was
ruled
initial
out?
thought.
Mhm.
Yes, that was initial thought because when they come in like that, we're all thinking COVID now, and so that was an initial thought. They said, could this be? And then as we looked at the criteria, or as they looked at the criteria and visited and then saw that it was not a COVID patient, then you have to be a COVID patient to qualify for that diagnosis, and this was a non-COVID patient, so couldn't make it fit. And alternatively, there was an illness that was identified that completely explained it, completely.
And so when you say ruled out, are you saying that you can do that after, let's say, it was on a death certificate as the cause of death, and it's in writing, and then you come back and it was ruled out, and then a doctor we'd have to do a whole nother death certificate? Is that usually, is that how it works? Or would you rule that out before signing or before a death certificate is filled out?
Usually when you do the death certificate, you have everything, mostly everything you need when they're inpatients. There might be, when you have people brought to, I've been in a situation before where I was brought people to the ER and there's nothing, there's no document, they're not known patients, and you have to come up with something, and you can't put cardiopulmonary arrest. They want an exact diagnosis. And my father's a case. He just passed away here at 101 and a half years of age. And I was wondering what they were going to put on the death certificate because he had no diagnoses. I mean, you don't get to be 101 and a half with a lot of diagnoses. So my sister and I were wondering what they were going to put, and they put something down, but he's never had a history of what they put down. So, but it was their best guess. So, and that's sometimes you don't have all the pieces of the puzzle, and you're not going to do an autopsy on someone his age. And so that's when it just hits you in the ER. On the other hand, when you have someone you followed in the hospital, you've been able to rule out those things before you fill it out.
Right. So, Doc,
so that would have been indicated. I mean, that wouldn't have been on the death certificate if, in fact, that this person did not die from.
In general, it should not have been. Yeah, and if someone filled it on incorrectly, they could modify it. Absolutely.
And that's totally normal.
Actually, we did have to modify my father's, not for that. We just left that because it was as good a guess as any. But for other things on the certificate, we had to modify it. So it was a simple thing to do.
Mm-hmm.
So where does the...
But it may be a simple thing to do, but when you talk to the family and say the family's notified that, he died from COVID, and there's those protocols that are in place when someone passes away from COVID where you have to do, the body has to be cremated, I understand, within 24 hours or buried. And then all of a sudden you notify the family, well, we've made a modification that your child didn't die from COVID, or this person didn't die from COVID. See what I'm saying? Like, it just seems for somebody to tell.
Time.
Yeah,
it's a terrible time for anyone in that setting, and then to have to rethink it. Yes, that's not good.
So, Doc, I mean, you're basically, as we've heard from Lillian, that this the child was placed in the COVID care unit,
right?
And so, just going back to everybody knowing that, would there be any disconnect between the hospital staff that took care of the child and the doctors who sign off on the cause of death? Would they be justified to put something like COVID on a death certificate, or are they out of the loop? Or I'm just trying to wrap my mind around how, I mean, because it looks like COVID, they're in a COVID ward, cause of death maybe COVID, and now you're saying that we can go back and change that. You know what I mean? It looked, the optics of it.
What happens is that some people are in isolation because they have something they can spread to others. Some people are in isolation, like chemo patients, who cannot be around anything. And so they're put in for their own protection because what you might bring in just as a common germ. Even, chemo, a lot of people on medicines that suppress their immune systems, they aren't able to eat bean sprouts, leafy vegetables, fruits, fresh, everything has to be cooked, pepper, anything with mold or bacteria on it, and all those things have that. They can't eat those because what it might do to them. So first of all, it's when they first roll in, you go, oh, it looks like it could be COVID. You haven't done any tests at all, just some basic labs, and you put that person in a room that protects them from others and protects others from them until you're still holding it in your hands going, what do we got here? What do we got here? Then you go, oh, this person has this on the x-ray. Oh, let's get that test. Oh, let's do a COVID test. Okay, get that test. And so with medicine, you tend to do the safest thing you can do right now. Hold that thought while I do this. And then the plot thickens and the picture starts developing and taking shape. And you go, okay, we've ruled out this. We've got this. Sick patient, don't move it. Keep it there. At least the patient's protected while you're doing all your other tests. And as other tests rolled in, that patient, when all the pieces came together, they went, oh, definitely not COVID. This person has this diagnosis, and this is what's happening.
Right.
And so that's what they were treated for. But when you first bring all the decision making in the ER is twofold. Bring them in, get them home. That's all you have to do in an ER. You do not have to make a diagnosis in an emergency room. That is not their job. All they're looking is to see, like, sometimes I would have people come in the ER and say, how's my cholesterol? I don't know. I'm dealing with your heart attack right now. Cholesterol is something you can scratch your head and ask next week when you're stable.
Right.
But the ER is admit or discharge. And then you go, oh, this one's coming in. And then the floor will ask you, what do you got? Well, I don't know. It could be this, but, it's all yours. Take it. And so then the floor takes it and puts them in the safest environment for them and starts the process. And what you think, you would be surprised the diagnosis they come in with. How many times they come in, diabetics, they come in, their heart rate will be fast, they're in congestive heart failure. Are you having chest pain? No, I'm not. And then sometimes they even might have a low grade temperature, and so the working diagnosis is probably flu syndrome. But you always go ahead and get cardiac enzymes because diabetics may not have chest pain as a symptom of their heart disease. So the cardiac enzymes, I've had them come back off the chart, and then all of a sudden changes the whole thing. Not flu syndrome, just nausea, vomiting, shortness of breath, and sweat is not the flu. You're having a massive heart attack. I have had that happen countless times, and actually I've seen people lose their license over it because they didn't think it, and they came in later not alive.
Right.
There are diagnoses that are, you have to think of everything when they come in, because when you think of the human body, what do we have? 20 symptoms for 2 million illnesses? Fever, yes, fever, no. Nausea, yes, nausea, no. Chest pain, yes, light switch. And you only have a few in your hand, and you have to narrow it down as quickly as you can to try, because you're playing catch up. Something's already ahead of you by the time they come in the ER, and you've got to run to catch it before it catches them. And so you act as quickly as possible in the ER and let the floor take it over.
Right, Doc. So it sounds like there's a lot of process. I mean, it's oversimplification, but there's a lot of process of elimination that goes on. But so knowing that, what happens when we have all these different processes that went on and COVID was ruled out, but then you get the doctors who, maybe what if the death certificate says COVID? Then how do you reconcile that? That's what I was talking about. Is there a breakdown in communication with what happens with the patient there? And we ruled out COVID, but then when they get it over to whoever certifies the cause of death, they're like, oh, it looks like COVID.
I think they would have to go back and revisit that if that's the case, because if it's not, in fact, the case that we're talking about had an exact diagnosis, so that made it a lot more simple in this case because of that. when there is a diagnosis and you've ruled out one and you've already ruled in the other with clinical criteria, you're done. Now, if something gets put on a death certificate that's incorrect, that can always be modified.
Okay, so it looks like that might have to be what's going to happen here.
So it sounds like you may have gotten word that COVID ended up on the death certificate. I don't know because I haven't seen it, but does it sound like that may be?
That's what it sounds like. Yes.
Yeah, that's what
that
it
it
sounds
is.
like.
It is
Yeah.
clearly indicated on documents that we have obtained.
Okay. Well, the information that I was given was that it was all non-COVID, and that's information from the lab evaluation and information on what the exact diagnosis was. So I wouldn't be able to explain. I can tell you this: if I knew, if I thought it really was a COVID death, and everyone thought that, we would have no hesitation in saying that.
Yeah.
I mean, there's no reason not to.
Mm-hmm.
But the information I got is that that was not the case. But if it were, it would be listed as that and would be treated as that. But that's not the information that I have on hand right now. That's not what I've been told. So, interesting if that ended up on a document. If it's truly not COVID, the document will have to be modified.
Right. And has that kind of thing happened? I mean, do you have any knowledge of that? Has there been other examples where a death certificate or whatever has said COVID and then it's modified?
No, none that I'm aware of. But we've only had 5 anyway, so it would be a real easy thing to know. But no, everyone's been. No, the community embraces it. If we've lost 5 wonderful people due to this, and there's no reason to shroud it in secrecy or anything. There isn't. There's no reason. I mean, if we had 20 deaths, we had 20 deaths, and the island would suffer more. But no, this case, as I'm told by some really reliable sources, non-COVID, and honestly. If it were COVID, we would say it. I wouldn't sit here and say I can't share that information.
Right.
We can share it. We're making everything public.
Yeah.
And really too, if you want to, I don't know, have you explored our
SIT report?
Our dashboard on the SIT report's good, but also something I just noticed, I was like, geez, where's the ethnicity on these? It's not on the SIT rep, but if you go to the dashboard on the DPHS website, at the bottom of that map that pops up on the dashboard, you'll see little arrows.
Yeah.
And I'm looking at the cumulative case count. I click on the arrow, then it comes out male, female, believe it or not, 50-50. Then the next screen, as you keep going, it's by age group. Then the next one's ethnicity. And that is not on the SIT. Both of those together give you a wealth of information. But those little arrows are hard to see. At the bottom of that, I hear your phone ringing. You'll have to get off.
Oh no, I totally dig the SIT report. Ever since you turned me on to that, I've been like on that SIT report.
Put the dashboard, because this dashboard thing, I think they added a couple weeks ago, and the little arrows at the bottom, you can go back and forward, and it gives you information that's not even on the SIT rep. Like you won't see ethnicity on the SIT rep except for the travel-related cases. But if you go to this dash is incredible. It really, it's really nice at what the EPI team has done. So yeah, but you want to play around with that one too.
Yeah, one thing though is it doesn't. It's hard to make those comparisons between like what the dashboard of the SIT report says the day before or when something changes, and so I'm constantly having to print out the SIT reports at least on a day-to-day basis so that I can make the comparison to the previous day and see where the changes are.
Exactly, I do too. Same thing, because it's a day-to-day report. Whereas if you look at the dashboard, it might give you a cumulative picture a little better.
Yeah.
Both reports together have a lot of information for people who want to look at those details, and you all do. I know you do. So. So check the dashboard map. When you click on COVID-19 on our website, you'll see the link at the top for COVID-19 Daily SIT Rep. But it shows you the link for community testing, though we've expanded it even beyond that right now. That'll have to be updated. But you'll see a map And it looks like a very harmless little map, but then scroll down and look at the arrows and then start scrolling through, and you'll see information that is not on the SITREP.
Mm-hmm.
It's a more cumulative picture, whereas the SITREP's a daily picture.
Mm-hmm.
So the two together should give you a lot of information.
Yeah, Bria is always on this. It's her homepage.
That's good, though. I mean, when in our lifetime have we ever seen anything like this? I mean, I didn't even know. SITREP didn't even come out of my mouth till this year. I've never even said those words, you know. When have I ever said KUAM before?
Right, yeah, well, hey, it's a blessing that we've been brought together like this, so.
I know. I said one more visit and you're going to have to rename it Redneck Media. It's not funny.
Yeah, it's not funny, don't laugh.
Why are you laughing?
Thank you, Doc. We appreciate your time.
Oh, no, I just need another half an hour.
Yeah, okay,
Yeah.
yeah, I'm down.
She needs her own show.
Yeah.
Hey, thanks for having me.
Of course. Thanks for
Thanks,
shedding light
Doc.
on that, and wash your hands.
Sure.
Okay.
Okay,
now.
bye.
9:51. Yeah, very interesting.
If you can, I mean, dphss.guam.gov. Lots of information from the situation report that we call the SIT report to the dashboard. It breaks down the
SIT
COVID
rep.
cases.
Okay, you guys have
quarantine,
no
everything.
idea how much Sabrina is fangirling over the SIT rep like every single day. Chris just said it's a homepage. I mean, some people are into like eHollywood News, some people are into ESPN. She's into the SIT reps. I mean, and she goes over it. And immediately she shares it with us in our group chat. She breaks it down, says, here's what the calculus was between the change between yesterday's numbers and today's numbers. But just the fact that we have something like this and it's
Yeah.
updated as often as it is fantastic.
Yeah.
It's a wonderful tool.
I had a question in the press conference, and it was something with the SIT rep. And one of the other media had messaged me after, like, "Hey, wow, you really read that, man? Good looking out." And I was like, "Yeah, that's all Sabrina."
But there's one thing I did want to ask Dr. Manglona. Maybe I can. Maybe
That's
I
a good
can,
thing you waited for her to hang up to ask.
maybe I can ask her like next time, because I mean it's such a wonderful resource, and it's formatted really nicely, and it's accessible in a sense that like anybody can pick it up and get a really good idea of what's going on.
Okay, what wins the internet? The DPHSS dashboard SIT rep or Department of Labor's apply, don't apply? Soft launch.
Oh, that's
We're going to go with
the
the dashboard.
I'm going to say for now that the SIT rep, only because of like it's got less problems,
Right.
it's less problematic. I mean, maybe we'll see after today at 2
So
o'clock.
nice,
but-
so nice,
Yeah.
this
But
guy.
one thing I want to ask Dr. Manglona is, next time we get her on, is it's so good like that. Being a woman of science, does she also plan to actually have the raw data be downloadable by anybody? Because like our friend, another doctor, Peter Lombard, and everything, he's done independent analysis of this stuff just by gathering and taking it. And there's a lot of people out there, data dorks like me. There's a ton of us on the island who would just love to put this stuff in a spreadsheet and crunch the numbers. You may be able to find.
Sound a little too excited about putting something in a spreadsheet.
Okay, well, this is what I geek out on. You guys fanboy and fangirl over the SIT rep. I would like to play with the raw data, and but it is possible, and that's why we live
Boy,
in
if
really.
I had a dollar for every time you said you want to play with your raw data, I mean.
I bet you
What
never
are we
say that on the air
what-
20 years ago.
What are we talking about here?
I don't know. We went left, so. Okay,
That's
Jay.
not a good note.
9:53. We are going to end on a good note. We're going to take a break and come back and end the show on a good note. Again, it's the KUAM News Takeover, Guam's favorite. Good morning.
Keeping you informed, KUAM News.